All right, substance disorders lecture continuing. So we were just talking about MAT, and it can be a lifetime of treatment for medical assisted treatment. So to talk about one of the drugs specifically, let's talk about buprenorphine, okay? So buprenorphine is like methadone. Buprenorphine suppresses and reduces cravings for the abused drug. It's a partial agonist of the mu opioid receptors. Formulations approved by the FDA for the treatment of opioid dependence include sublingual buprenorphine and sublingual buprenorphine / naloxone tablets and or strips, okay, otherwise known as Suboxone, okay? So there is a Subutex and a Suboxone. The naloxone component of Suboxone is poorly absorbed in the sublingual route and present only to prevent misuse of the medication by crushing or injecting the combined product. Because of that safety feature of the buprenorphine / naloxone, then that is the preferred formulation so that they're not being able to get high or misuse it or crush it to get more of a feel from the medication, because it does have that underlying naloxone component. Brief treatment periods with rapid medication tapers, so for medical withdrawal, are associated with high rates of relapse. Therefore, long-term or maintenance treatments is generally indicated for patients with opioid dependence. So, and that goes back to the whole, how long they have to be on this medication. It may be the thing that works for them. You're going to see, I notice more and more with pain clinics picking up on Suboxone and using it more for that route, but that's one thing to investigate with your patients is, what are you taking these medications for? Are you on methadone for pain? Are you on Suboxone for pain? Are they using it specifically because you have a history of opioid use, and kind of looking at that long term, or how long do you have to be on a certain medication? So naltrexone, narcotics such as morphine or heroin produce their effects again by stimulating those receptors known as the mu receptors, okay? And they are kind of working as that mechanism of action as morphine, all right? So the stimulation of the mu receptors is responsible for pain relief. Again, I'm mentioning used in chronic pain in these pain clinics, and the pleasure response to these drugs. These receptors also seem to be involved in the pleasure response triggered by during alcohol consumption as well. So that is something to be very on alert for, is that interaction possibility, okay, between naltrexone and alcohol as well, all right? So the mu receptors are located in the brain and central nervous system, and also in the intestines, which is why narcotic drugs can cause constipation, and you're going to hear that a lot. These synthetic type opioids can still cause constipation issues, even those patients who are on methadone and so forth. Because they're stimulating those mu receptors in the intestines and then causing their normal movement to slow down, we have these issues. Now, naltrexone blocks these receptors so they cannot be stimulated. Naltrexone does not stimulate the receptors, it just blocks them from being capable of stimulation. So if you can imagine that mu receptors are like the keys of piano, and then naltrexone is the pharmacological equivalent to closing the cover on the keys, okay? So the keys, all right, are still there, right? But it just closes the cover, all right? Drugs available include, so there's naltrexone tablets, there's the Revia tablets, and there's even the Vivitrol injection, which more people are more familiar with, to try to help people to discourage them from these cravings, because it's blocking those receptors. It's so that you cannot get the same effect, as I was just mentioning, that interaction with the alcohol, okay? You can't get that same effect that you used to, so maybe, hopefully, your brain will not want to drink, not want to use these medications, because this is blocking that same reward center effect that you were getting prior. Now, due to naltrexone's ability to block the euphoric effects of these drugs, regular administration can help patients overcome psychological addiction. Because the tablets need to be taken daily, or sometimes even 3 times per week, it does require that the patient actively participate in their treatment, which is a good thing, though. You have to be, in substance abuse here, you have to be ready. You have to be ready, and you want to change, okay? Your family cannot just push you into something, make you, threatening you. Even there's court-ordered people who they're court-ordered to go get treatment, but you really, ultimately, they have to be ready and want the change. The Vivitrol injection offers the advantage of being given once a month. So if there is someone seeking to abuse narcotics, then they're gonna see that, oh, this didn't work. I'm not getting the same effect I used to. What's the point of this? Okay, so their cravings are going to go down, and that once a month is very nice for those who are very non-compliant with their medications. Remembering it's another option for those patients to hold them with their sobriety. Opioid overdose prevention medications. So there is naloxone, or otherwise known as Narcan, Do not confuse it with naltrexone. Okay, naloxone is our Narcan. All right, naloxone is an ingredient in several prescription drugs. It is in Talwin. It is in Suboxone, okay, which is the buprenorphine naloxone mix. But remember that naloxone part keeps the buprenorphine from being abused, okay. And then there is Narcan and the Vivitrol injections as well. Now, naloxone basically has the same pharmacological effects as naltrexone, but shorter acting, thus it makes it more use of a revival drug, okay, then necessarily it's not a long acting that's going to prevent the abuse or not the getting the same effects, that pleasure from using, but instead it's more of a whoop, quick go in, go out to help us revival to get things better now. So if you've overdosed on heroin and barely breathing and almost gone, we can give you that Narcan injection and help to revive you back. It's going to take that high away really quick. Now, on the opposite end of that, if anybody's ever worked EMS, be aware though that when you've all of a sudden taken someone's high away from them rather quickly, your body has not had time to adjust from coming off that substance. So to be completely withdrawn that quick, you can have a reaction be very assaultive or belligerent or upset and mad at you because that high is no longer there. Okay. So alcohol use disorder medications. So let's talk about this disulfiram, acamprosate, and naltrexone that obviously are most often used for alcohol disorder. And that disulfiram is Antabuse, if anybody remembers our Antabuse. So speaking of Antabuse action, so it is considered an aversion therapy. And if you've ever heard of aversion therapy, it's kind of like that whole, how do I prevent myself from biting my nails? Well, maybe you or a child sucking their thumb and you put something bitter, sour, something like a Band-Aid. So I don't want to bite my nails because I'm not getting that same reaction or something's deterring me. That aversion therapy, okay? So a disulfiram is a medication that treats chronic alcoholism. Most effective in those who've already gone through detox, though, or initial stage of their abstinence, okay? You may see someone come out of rehab prescribed Antabuse. So it is taken in tablet form once a day, should never be taken while intoxicated, and should not be taken within 12 hours of drinking because it's going to cause that aversion therapy side effects. It's going to cause those unpleasant, nauseous, headache, vomiting, chest pains, difficulty breathing. Oh my gosh, why would I mix these things, right? So, but it even occurs just as soon as 10 minutes after drinking, even a small amount of alcohol, and it can last for at least an hour or more to have these feelings, these side effects, okay? When alcohol is consumed while they're taking this, the patient may feel flushing, tachycardic, and even other symptoms. And this is not, so teaching, if we go back all the way to nursing school type teaching, is we're not just avoiding alcohol. You really have to be mindful alcohol-containing products. So this is certain mouthwashes, certain cough medications, certain maybe there's wood stains or things in your house that you're using that you need to be aware of. If they're alcohol containing, this can still cause you to have that disulfiram reaction. So make sure that you're educating patients if you're going to use this to avoid any alcohol containing substances. All right, acamprosate decreases the cravings, but can sometimes be also referred to as artificial alcohol. It's a medication for people in recovery who've already stopped drinking alcohol and who want to avoid. It can help to prevent people from wanting to drink, but does not necessarily prevent the withdrawal symptoms after you drink, okay? So it's preventing, again, that want, that desire, but it's not going to do anything to help prevent the withdrawal from the alcohol itself. So it's not been shown to work in people who continue drinking alcohol or consume illicit substances. It typically begins on day 5 of abstinence, okay, and reaching full effectiveness within 5 to 8 days thereafter starting. It's often in tablet form, but unfortunately does have to be taken 3 times a day. So if you really think about those people being compliant, is it something, can they remember to take a medication 3 times a day? And be compliant with their dosing to keep away and stir them from those alcohol desires. The medication side effects may include diarrhea, upset stomach, appetite loss, anxiety, dizziness, and even difficulty sleeping. Naltrexone, when used as a treatment, or naltrexone, we talked about that already a little bit for opioid, but it can also be used for alcohol dependency. It, again, is blocking those euphoric effects of the intoxication, right? And we talked about that. So it's allowing them to reduce their drinking behaviors and make motivated and easier to stay in treatment and sobriety because of not having those cravings and less likely to go into a relapse as long as you're continuing to take that medication. Other pharmacologic interventions we can use are benzos. Obviously, during the SIBO protocol, we may have to use a short-term, keyword short-term, use of benzos to help us, whether it's Librium or Ativan, to help come off of the substances as well to prevent the seizures. There are anticonvulsants that have had studies such as Topamax and gabapentin that have studies to decrease the want, the desire, okay, the craving for alcohol use as well, and not a bad thing if someone is to try to prevent the seizure likability after coming off of the substance. Beta blockers we can use for the anxiety and the tremors and things with withdrawal. Also physiologically calming to help with some of those, the heart racing symptoms from withdrawal and anxiety. Haldol, if they're going into psychosis, delirium, we may have to pull out the Haldol vitamins, such as we talked about the thiamine. For opioids, we can actually use clonidine. It is also a great thing to help with, again, some of those withdrawal symptoms of coming off from the opioids. Benzodiazepines are to coming off. If we're coming off of benzos or detoxing, we can use phenobarb to prevent seizures and the reversal agent. But again, you need to be mindful. Romazicon can be, or flumazenil can be given in the emergency room, but what is that reaction when you take that high away? And for this person, not even necessarily take that high, but if you automatically give something to, again, take away all that CNS depression on the brain, their person can be at risk for seizure, okay? When you automatically abruptly stop that high, heavy dose of benzo use and you give the reversal agent or Romazicon, you still need to be mindful and watch, assess for seizure. So lastly, I want to end you guys with this. Please take time and look at this link for YouTube, and I hope that the link carried over correctly. It is called Nuggets. If you look it up on YouTube, it's absolutely, I think it's one of the best videos that's come out there to really show you or try to characterize what it's like for a person with addiction and what addiction's like and means for that person. And I want you to comment in the discussions, you know, what are your opinions and thought of what is the video showing? What do you think that the meaning is of the darkness at the end with the little nuggets? Kind of like a bird, that kind of little nugget. But watch the video, see what you think. Let me know your comments. I hope that you guys can take away from this and learn. And also, anytime you're dealing with substance use, we really need to have some self-reflection as well. So make sure that as we're going through this and as your provider out there taking care of these patients, that you really self-reflect on what your beliefs are, and then so that you are also not stigmatizing that person or prejudging them based on their looks or their use, and really, you know, take a step back. Just as, you know, maybe you have a caffeine addiction, or a Mountain Dew person, or have to have your cigarette, you know, what makes me getting up and have to have a coffee to get my day going any less worse than the patient who has to get up and have a crack rock to get going in the day? And you think about, like, well, that's because of the effects and the, okay, yeah, and one's legal and not, right? But in reality, again, really think about it in that part of the brain. Okay, this person's going to have to use this drug to get through the day, and maybe you need your caffeine to get through your day. Okay, so work on self-reflection, work on how you're thinking to work with these patients, and watch this video and see if that make any mark on you. If you have any questions, as always, please reach out. Always feel free to email. I encourage you to continue to post and participate in the community of the drug autobiography presentations. And I will be around. So thank you guys so much for this. There's our references. Y'all have a wonderful week, and see you in the discussion forums. Thank you.